For joining us today. I, Amita, along with my teammates from Jagsonpal Pharmaceuticals Ltd, Dr. Deepika Chhabra, are delighted to welcome you all to today's scientific Sangam 17 organized by ISOPARB Prayagraj in association with Ludhiana and Jalandhar Obstetrics and Gynaecology societies, with academic partner Jagsonpal Pharma Ltd, makers of DIVATRONE 10 mg tablets of Dydrogesterone. Today's discussions are brought to you by Jagsonpal Pharma Ltd, makers of Lycorate soft gels containing lycomato, maintained injections, hydroxyprogesterone, caprolate 250 and 500, and newly launched DIVATRONE brand of micronized dydrogesterone. A warm and hearty welcome to esteemed experts and attendees. Dear attendees, we request you to post your questions, queries, suggestions by text in Q&A box. Please note this webinar is streaming live on Facebook and the link has already been shared on the chat box. To refer this webinar in future, please visit our YouTube channel, Jagsonpal Medical Insights. As we initiate today's session, we request Coordinator Dr. Ranjana Khanna Ma'am, Vice President FOGSI 2017, Founder President ISOPARB Prayagraj, and ICOG Governing Council Member to kindly initiate this session.
At the outset, I think we will begin first of all with prayer to Lord Shiva. First of all, I want to warmly welcome Dr. Rishma Pai, who is the chief guest for the evening. I have had a very close association with Dr. Rishma, and I know her to be a wonderful human being, both inside and outside. She is so dynamic, such a perfectionist that I have always admired her for that. When I was Vice President FOGSI in 2017, she was the president of FOGSI. So I welcome you, Dr. Rishma. She has been the president of FOGSI, I have just said, in 2017, president of Mumbai Obs and Gynae Society, president of ISAR, president of IAGE, assistant treasurer, International Federation of Fertility Societies, and she's a consultant gynecologist in Leelavati, Jaslok, Hinduja, and she's got several awards, and to her credit, she's been awarded the Inspiring Gynecologist of Western India by Times of India, recipient of Midday Health Wellness Award as icon in OBGYN and infertility, recipient of the Women Empowerment Award by the Indian Medical Association. She's got so many awards, recipient of the Bharat Nirman Award, recipient of 50 Outstanding Women in Healthcare Award. I fully endorse all this, you know. Women's Achievers Award, awarded the Newsmakers Best Doctor Award, the Nav Shakti Award, and you have given so many orations, and you've been an invited speaker, and you're a wonderful orator. And we are waiting for you, Dr. Rishma, to give a small talk on encouraging us and my forthcoming conference too.
Thank you. Thank you so much. Good evening to all of you. What a privilege to be here amongst all of you today. I've always maintained that I can never say no to Dr. Ranjana. She is such a warm, loving person. Look at her smile. It'll just win everyone over. So when she said to me, join me, even though it's a working day, in the middle of a working day, I said, of course, I'll be there. No issues at all. And it's truly wonderful. I think Dr. Amita, I already said to her before we started how dedicated she is and so much of a perfectionist. So it's wonderful to be working with this group of people who are really dedicated towards academics. And I'm happy today that you're focusing fully on a very, very important subject of fetal growth restriction. All of us know, and Bill Gates has very rightly said, that treatment without prevention is simply unsustainable. So if you keep on treating babies, who are coming out in not such perfect health, it's really not a sustainable effort. So we all have to pick up the problems very, very early and do everything in our capacity to prevent it from happening. So predicting them, preventing them. And it's wonderful that we have Ranjana, who's dedicated so many years to the practice of obstetrics. My friend, Dr. Pragya, again, very, very dedicated academic person speaking, and so many of you there to sort of participate and give your comments. So I think it'll be a very, very sort of a fruitful session. And really, I truly believe that true prevention is not really waiting for bad things to happen, just preventing them from happening in the first place. So with all your efforts, with a very forthcoming, very enthusiastic organization and company like ISOPARB and Jagsonpal in behind supporting all of you, I think all of us will make a lot of progress. So thank you for having me with you all today. And I really wish all of you the best for this webinar. And of course, big wishes for the big program of Dr. Ranjana Khanna coming up very soon. She is really putting a lot of effort into it. So I'd like you to say 2 words about that program so everybody listening in knows what to expect from you, a very, very focused and a very, very large event that you're planning. So do speak to us about it, and we look forward to listening to all the experts today. Thank you once again for giving me this honor, privilege, and thank you for all this, and I hope to all of you have a wonderful, wonderful time. Thank you.
Thank you so much, Dr. Rishma. The pleasure was entirely ours.
Thank you.
So thanks a lot for coming. And
hear a little bit about your conference before the actual webinar starts.
Yeah. Thank you so much for that.
About your conference.
Yeah. Huh? Actually, I am doing a FOGSI conference on obstetric dilemmas. You know, when I was doing my post-graduation, there was always a dilemma in treating patients. Those days we didn't have ultrasounds also. So it was, you know, now will this baby come out good? Should we leave it a bit more inside? Yeah. Or should we take it out? What if we leave it inside and the child dies in utero? And what if we take out the child and the child dies of prematurity? So there were, and not only this, there were so many dilemmas all the time. With the advent of ultrasound, color Doppler, CTG, of course, things have improved, but the dilemmas are still very much there. And I think obstetricians have to be really focused because they have 2 lives. One is the mother and one is the child. So we are responsible for 2. In every other profession, it is only 1 patient. We have 2 patients, one inside the other. So we have to be equally careful about the mother and the baby. So there's so many obstetrical dilemmas which we have in our day-to-day practice of obstetrics, which I think is one of the most fascinating subjects ever. So that is why I was very keen. And if you remember, Dr. Rishma, then in 2017, I did Bad Obstetrical History, the Triology.
Wonderful.
And that was in Delhi with AOGD. So it's basically about obstetrics and my fascination.
Dilemmas is I think every patient is a dilemma. All the PIHs, the diabetes.
Yeah, it's always there.
Everything is a dilemma. So
Exactly.
thank you for bringing that important subject up.
Yeah.
And, I'll switch off my mic and start listening to all of you and maybe gain some good knowledge today. Thank you.
Thank you so much. Thank you so much, Dr. Rishma. Now, I think, Amita, you take over.
Thank you, Ranjana ma'am. Welcome to all the faculty delegates, especially the Jalandhar and Ludhiana societies, for being with us and joining us in this journey. And at the start, I would like to invite Dr. Ginny, the Secretary of Ludhiana Obstetrics and Gynecological Society, to start the first session. She has a special interest in safe motherhood, high-risk pregnancy and adults in gynecology, and she is a member of All India Women Federation, member of SMF. Over to Dr. Ginny to conduct the first session.
Thank you, ma'am. Thank you. At the outset, we would like to thank you and Dr. Ranjana for organizing this beautiful webinar on such an everyday and a pertinent topic which continues to baffle us to deliver or not to deliver and when to deliver. So I will quickly invite my two esteemed chairpersons for the first session. One is Dr. Surjeet Kaur. Madam is a veteran of OB-GYN. She is an experience of 45 years in the force, and she is director of Parivar IVF Center, president of Jalandhar OB-GYN Society, and vice president of the ISAR chapter as well. So herein you have a mixture of obstetric knowledge and ART knowledge as well. So welcome, madam. We would love to have you as a chairperson with your words to guide us. I also welcome Dr. Vineet Kaur. She is our teacher and guide always from Ludhiana, ex-professor and head of OBG CMC Ludhiana. She is fellow of the Indian College of OB-GYN, and she's also past president of our society, and she is the harbinger of corporate healthcare in Ludhiana, who is running a corporate hospital herself. So I welcome Dr. Surjeet and Dr. Vineet, both professor candidates. Please come and start the session with speaker as Dr. Ranjana. Please welcome and introduce Dr. Ranjana. Madam needs no introduction. Dr. Surjeet and Dr. Vineet, over to you, please.
Good evening, all the viewers, Dr. Rishma, and all the chairpersons, all the faculty members. First of all, I thank Dr. Ranjana for arranging this wonderful webinar and making me a part of this. So, as we know, today we are going to discuss about the fetal growth retardation. It is associated with multiple short and long-term consequences for the infant. A woman with prior gestation with FGR has 20% chances of FGR in the next pregnancy. FGR is a condition in which unborn baby is smaller than the expected for the number of weeks of gestation. It is often estimated as the 10th percentile. 10th percentile means the baby with this weight is having lesser weight than the 9 babies out of the 10 babies of the same gestation age. Fetal growth retardation babies are also called small for gestation babies. As there are many causes, there can be placental causes when the placenta implantation takes place in the trophoblastoid action. And there can be problems in the umbilical cord with the blood flows. There can be many causes for the FGR. High blood pressure, diabetes, anemia, long time kidney diseases, poor nutrition, poor weight gain, alcohol, or other drug uses, cigarette smoking. And out of this, we have to do the proper management. That is frequent monitoring, frequent visits to clinic, frequent ultrasound visits, and color Doppler studies, tracking of fetal movements, low dose aspirin, good diet, and protein-rich diet. If there is any suspect of the high resistant flow in the uterine arteries, in those cases, we should start with the 75 to 150 milligram of aspirin before the 20 weeks. And if the dual marker report in PEPA value is less than 0.5, then also we should start the aspirin. So now I request Dr. Ranjana, but before it, I introduce her. She is a senior consultant and director, Ranjana Hospital, Prayagraj. She is a national vice president, FOGSI, 2017. Founder, president, Prayagraj chapter of ISOPARB 2021-23. ICOG Governing Council member 2021-23.
Slide, please.
President, AOGS Allahabad 2013-16. Honorary Secretary, OGS 2011-12.
I think that
Organizing number of faculty at various national and international conferences and webinars. He is a national awardee, FOGSI Smriti Island Award, Save the Girl Child, AICOG 2030. FOGSI Dr. D.K. Tank Reproductive Health Care Promotion Trophy, AICOG 2015. She has special education Safe Motherhood Committee at AICOG 2040, Public Awareness Committee and Welfare Committees, and so many things you are correct. Now I request Dr. Ranjana to start her deliberation.
Thank you so much for the wonderful introduction. My topic today is fetal growth restriction, which is so very important nowadays with increasing age of marriage and so many other factors. Preventive aspects and obstetrical management. Fetal growth restriction is defined as a fetus estimated to weigh less than 10th percentile for gestational age. Small for gestational age is usually a neonatal term to define a birth weight of less than 10th percentile for gestational age. Now, what is the pathophysiology of fetal growth restriction? About 60% of the fetal growth is determined by genomic factors, with 40% contribution from environmental factors. Epigenetic processes such as imprinting, methylation, and transcriptional depression regulate growth according to environmental stimuli. Insulin growth factor 2 is the main hormonal modulator of embryonic growth in early pregnancy. Placenta has principal influence on birth weight. In normal pregnancy, the trophoblasts invade the spiral, endometrial and myometrial arteries, remodel them into widely dilated uteroplacental arteries, causing uteroplacental flow impedance to progressively decline and maternal blood flow into the intervillous space to increase exponentially. In FGR, this remodeling can be deficient, which can sometimes be detected by uterine artery Doppler, resulting in endothelial dysfunction, shallow placentation, fewer spiral arteries, increasing resistance, less nutrition, and hypoxia. These changes can lead to fetal growth restriction, preeclampsia, and spontaneous preterm birth, which may share some common pathophysiological mechanisms. Review of history and records of prior pregnancy is essential. Occurrence of fetal growth restriction should be verified by review of dating criteria, gestational age at birth, and birth weight percentile, management interventions, and postnatal cause and risk factors. Hypertension is associated with 30 to 40% cases of fetal growth restriction. This is a neonate born after diagnosing FGR. Now, what are the causes? They could be in the mother, the fetus, the placenta. In the woman, it could be poor gestational weight gain, constitutionally small, poor nutrition, social deprivation, eating disorders, drugs and teratogens, infection, fetal malformations, maternal medical conditions, genetic abnormalities or multifetal gestation, placenta or cord abnormalities. The risk factors for FGR could be history-based risk factors, maternal demographics, advanced age, underweight, living in high altitude, severe anemia, hemoglobinopathies, environmental factors, medical conditions like chronic hypertension, CKD, SLE, inflammatory bowel disease, APLA, pre-gestational diabetes, obstetrical history, previous pregnancy affected by FGR or preeclampsia. Biochemical markers, low PIGF, low PAPA, high AFP. Ultrasound-based markers, more will be talked about by Dr. Pragya, but we will look into the uterine artery pulsatility index and the artery bilateral notching, but the details will be discussed later. Now, the growth charts. Actually, the fetal growth has to be charted along the, in the growth charts. They are the universal growth charts, which are by WHO. But we all know that the Indian babies are potentially much smaller than the Western babies. So we need our own customized growth charts. So it is always better to plot the fetal growth, the growth velocity on these customized growth charts as opposed to the universal growth charts. Key recommendations are symphysis fundal height is a simple and inexpensive tool that can be used as the primary screening strategy for FGR in low-risk pregnancies in both low and high resource setting. Local or regional growth charts, we have talked about it, should be preferred over the universal charts. Alternatively, universal standards may be used with locally adjusted thresholds to avoid over or under detection of FGR. Criteria from Delphi consensus, including both biometric and functional parameters, should be used to define FGR. We won't go in details of this. Confirming gestational age, early ultrasonography at less than 20 weeks is the best method to estimate the gestational age. Crown rump length measurement at approximately 8 to 13 weeks is the best method to estimate the gestational age. This is an ultrasound picture showing us the CRL. Now, how do we prevent fetal growth restriction? That's very important. In preconception visit, healthy lifestyle modification is to be stressed upon. Optimize any comorbidities if present. Optimize the BMI. Recommended gestational weight gain is 12.5 to 18 kg in underweight women and 7 to 11.5 in overweight women. Counsel that short interpregnancy interval is associated with an increase in FGR by 40%. Optimal interval between the last pregnancy and the next conception is 18 to 24 months. Smoking cessation programs are associated with 19% decrease in LBW and perinatal morbidity and mortality. Alcohol intake is also prohibited. Bed rest does not prevent low birth weight and has been associated with a significant increase in preterm birth in certain populations. Nutrient supplementation. Magnesium is the only micronutrient that might be associated with a 30% decrease in small for gestational age in low-risk women. Zinc supplementation did not reduce the incidence of SGA, but it is unclear if the women who were studied were actually zinc deficient or not. Vitamin D supplementation in winter months was associated with the trend for benefit in preventing FGR in a small trial, but further research is needed. Preventing FGR medical interventions, aspirin. In women with high risk of PET, administration of aspirin 100 to 150 milligrams daily at night, starting at or before 16 weeks of gestation, reduced the risk of FGR by nearly half. LMWH, enoxaparin for preeclampsia and IUGR, the EPPI trial showed no difference in the rate of composite outcome. LMWH cannot be recommended for preventing FGR according to latest evidence. Its use in FGR is limited to research settings. So, how do we diagnose fetal growth restriction? Accurate dating is essential and may be best accomplished with the first trimester ultrasound examination. Owing to association of fetal anomalies with FGR, 18 to 22 weeks ultrasound examination may be useful. Best ultrasound parameter for prediction of FGR after the first trimester is the abdominal circumference. Other important parameters are estimated fetal weight, ratio of head circumference to abdominal circumference, ratio of abdominal circumference to fetal length, and the Doppler changes. Uterine artery Doppler studies have 50 to 75% sensitivity for FGR in high-risk women, including women with prior FGR, but an unacceptably low sensitivity in low-risk women. Only studied intervention for prevention of FGR or preeclampsia upon detection of abnormal uterine Doppler has to date been only low-dose aspirin. Management, particularly in early onset FGR, maternal vascular malperfusion retain smooth muscle cell function of spiral arteries appears to be predominant pathophysiological pathway. Suboptimal remodeling of uterine spiral arteries has led to pharmacological strategies that influence uteroplacental vascular function through endothelial nitric oxide pathway and vasodilatation. No strategy, however, is there with established efficacy. Coming to sildenafil, early evaluations of phosphodiesterase 5 inhibitors, that is sildenafil, as therapeutic treatment for early onset severe FGR with a high risk of fetal demise appears promising. An international collaboration, acronym STRIDER, the RCTs were done of antenatal sildenafil citrate for FGR, and they showed no benefit and possible risk of neonatal pulmonary hypertension. Coming to arginine, antioxidants. Arginine, it is a nutritional supplement, unlikely to have unexpected, unwanted side effects as seen with sildenafil exposure in the Dutch STRIDER RCT. Recent cross-species meta-analysis combining all available data from human and non-human studies suggests that arginine and nitrogen carbamoyl glutamate supplementation does improve the fetal growth in complicated pregnancies. So there's a ray of hope here. Gene therapy. Promising approach is the VEGF gene therapy, in which adenoviral vectors encoding for proteins such as VEGF are introduced to the maternal uterine artery. In preclinical studies, it increases the uterine blood flow and reduces the vascular contractility. This method is anticipated to be safe as no vector seems to spread to the fetus and no adverse effects on either mother or fetus have been observed. This strategy requires, however, extensive clinical trials before it can be implemented into clinical practice. So now, in a nutshell, is delivery the only management option for FGR? Fetal growth restriction implies that the fetus suffers most from nutritional exchange, and sustained nutritional deprivation is rarely the cause of fetal demise. It is lack of oxygen supply to the fetus, resulting in chronic or acute hypoxia that leads to perinatal death. Only management that actually treats placental insufficiency is delivery, which prevents stillbirth but predisposes to postnatal death from prematurity. Early onset FGR is rare, 0.3%. This extreme phenotype has significant individual impact owing to aggravated effects of prematurity, death or survival with severe impairment. All severe morbidities are actually expressions of underdeveloped organ functions, including lungs, bronchopulmonary dysplasia, RDS, bowels, necrotizing enterocolitis, immune system, sepsis and meningitis, and cerebral blood vessels, intracerebral hemorrhage, and periventricular leukomalacia. Timing of delivery. Now, the timing of delivery is based on an estimated balance of risk of ongoing intrauterine hypoxia versus consequences of iatrogenic premature delivery. In a pre-viable period, consideration of expectant management is warranted even when fetal death is expected, because delivery often confers near certainty of postnatal death from prematurity. In scenarios whereby severe fetal compromise is present before viability, pregnancy termination should be made available when continued expectant management is associated with maternal risk. Viability may occur at a later gestational age for fetuses with FGR, and determination of moment of viability depends on the expertise, the experience of obstetric and neonatal staff. So this is umbilical artery Doppler velocimetry studies. Just look at C. We must all be familiar with this graph because during diastole arterial flow is reversed. This is an ominous sign and that may precede a fetal demise. Coming to CTG, fetal heart rate is a function of autonomic nervous system. We all know that. At the onset of hypoxia, FHR variability decreases, whereas progressive hypoxia and acidemia result in spontaneous decelerations when repeated decelerations occur. And these decelerations are unprovoked by uterine contractions. There is a strong consensus that imminent delivery is warranted because hypoxia is already present and the risk of stillbirth is very high. So importance of low FHR variability, however, is less clear. But short-term variation, this is measurement of FHR variability that is calculated by computer analysis. This avoids high inter-observer and intra-observer variability of visual CTG observation. Ductus venosus, use of ductus venosus Doppler waveform in addition to CTG to determine the timing of delivery. At age of 2 among surviving infants, it is likely that intrauterine malnutrition and hypoxia affect some fetal organs before others. In fetuses with early onset FGR, cardiac dysfunction may precede this cerebral dysfunction. Combination of CTG and Doppler evaluation of ductus venosus as monitoring modalities to time the delivery is likely to be synergistic in achieving optimum results. Finding of truthful trial are difficult to generalize to practice settings. So you have to be actually very good at identifying the DV Doppler waveforms and then correlating it with the CTG. And of course, we will come to the biophysical profile now, which also has to be seen. The biophysical profile score is a crude composite score of combined assessment of fetal movements, reactivity of CTG, and assessment of amniotic fluid. Association of an abnormal biophysical score with adverse outcomes of interest is not as good as the other available parameters which we have been discussing. Now we come to late onset fetal growth restriction from diagnosis to delivery. In late onset FGR, when placental reserve is already challenged, the interval between onset of nutritional deprivation and life-threatening hypoxia is typically shorter than in the early onset FGR. In this gestational age period, the concept is easy to manage, but very difficult to diagnose. DIGITAT study. DIGITAT study has randomized women with fetuses suspected to have FGR at 37 weeks of gestation to delivery or expectant management, showed no difference in primary outcome of short-term perinatal morbidity. More fetuses in the expectant management were in the lowest birth weight percentile group, and these were fetuses who were at risk of later developmental delay. This study shows that what is most important is selection of the fetus at risk, and that is still imperfect, and the ideal approach is still not clear. Corticosteroids and magnesium sulfate, they do play a very important role. Benefit of a single course of antenatal corticosteroids to accelerate fetal lung maturation for spontaneous premature delivery has been unequivocally established remote from term. It is appropriate to offer this potentially potent preventive therapy as it is endorsed by professional societies. Findings from studies assessing magnesium sulfate for prevention of eclamptic seizures was reduction in risk of cerebral palsy, and several studies have confirmed that magnesium sulfate has a neuroprotective effect and can reduce the incidence of cerebral palsy when given to women at risk of early preterm delivery. So in a nutshell, a patient comes to us before 34 weeks So if it is less than 24 weeks, deliver if maternal status indicates. Otherwise, repeat ultrasonography every 3 to 4 weeks. Now, if it is between 24 to 34 weeks, evaluate maternal status, comorbidities, umbilical artery Doppler velocimetry is done, fetal testing, NST, BPP, etc. Consider steroids for lung maturation. Now, consider delivery if there is reversed end diastolic flow. We talked about this. Non-reassuring fetal tracing, maternal or obstetrical indications if they necessitate delivery. If there are no indications for immediate delivery, begin antepartum fetal surveillance, regular fetal testing, weekly umbilical artery Doppler velocimetry, weekly evaluation of amniotic fluid levels. Repeat sonography for fetal growth every 3 to 4 weeks. Now, if we find that the fetus is growing, let the fetus grow and let the antepartum fetal surveillance continue. If the fetus is not growing, then consider delivery. Now we come to a fetus when it is 34 to 38 weeks. Evaluate maternal status and comorbidities. Again, umbilical artery Doppler velocimetry, fetal testing. Consider delivery if there's absent or reversed end diastolic flow, oligoamnios, non-reassuring fetal tracing, maternal status, or if there are obstetrical indications that necessitate delivery. If there are no indications for immediate delivery, then keep the patient on antepartum fetal surveillance. Repeat sonography for fetal growth every 3 to 4 weeks. If there is fetal growth, then continue till 38 weeks. If there is no fetal growth, then consider delivery. So to conclude, clinical care points, the most common mechanism in fetal growth restriction is suboptimal remodeling of the uterine spiral arteries, leading to smooth muscle cell vascular reactivity of the maternal vascular bed, resulting in high resistance placental circulation without a constant large amount of low velocity maternal blood flow into the intervillous space. Doppler ultrasound of the uterine artery, umbilical artery, middle cerebral artery can be measured throughout pregnancy and provides an indication of placental function. The main obstetric decision for fetal growth restriction remains the timing of delivery. In early onset fetal growth restriction, management hinges on weighing the risk of prematurity versus the risk of fetal hypoxia. In late onset fetal growth restriction, the clinical challenge is the correct diagnosis of the fetus at risk for hypoxia. Thank you so much. And before I conclude, I welcome you all to our National FOGSI conference on obstetric dilemmas. It is on 6th and 7th of August 2022, and it is hosted by Allahabad OBGYN Society. And we are all waiting with folded hands to give you a wonderful scientific bonanza at the conference. Thank you all so much.
Very nicely, in such a short span of time, you have covered almost everything.
Yeah.
So the take-home message or whatever we learned is that we have to be vigilant for identifying these FGR babies in women who have risk factors, as well as also once in a while we might get a woman who has no risk factor. So we have to be clinically very vigilant to pick up these babies, to identify these pregnancies. Aspirin is the only standard preventive measure which we know. There is not much as far as now available for treatment part, but monitoring these pregnancies is important. And it is only by serial ultrasounds and Dopplers. That's now rather becoming mandatory.
Yeah, that's what I was saying in our times. In our times when we were doing our post-graduation, then we did not have ultrasounds. Then that was the difficult part. It was all clinical judgment, you know, when to deliver, should we or should we wait? So now we have a lot of help, but still the timing of delivery is still an enigma, no doubt about it. And FGR continues to be an enigma for us.
Timely intervention is the only thing which helps these babies to have some prevention from short-term and long-term consequences. And it's medically important to deliver such women in a tertiary care center where there is facility of a NICU. Thank you so much, Dr. Ranjana, for an excellent talk.
Thank you, esteemed faculty. Dr. Ranjana ma'am, we are once again reminded of your academic excellence and your undeniable national faculty caliber. Thank you, Dr. Vaneet ma'am and Dr. Surjeet, for chairing the session from our Punjab side. Now I invite again Dr. Amita once again to take over, and we proceed to the session 2. That is the color flow mapping and the Doppler studies in IUGR. Madam is honorary secretary and founder of ISOPARB Prayagraj, and she has been great and magnanimous enough to organize this whole meeting under Dr. Ranjana and involve Jalandhar and Ludhiana societies. Madam has many credentials. She's chairperson AMA Prayagraj, consultant OB-GYN Allahabad. She's VP of the Allahabad Society was from 17 to 18 and honorary secretary of the Allahabad Society from 13 to 16, and she has so many achievements and has stood on so many important prestigious posts. Madam, I invite you. I thank you once again and invite you to start session 2.
Thank you, Dr. Ginny, for kind introduction. And after the delightful talk by Dr. Ranjana Khanna ma'am, let's move towards the next session, which is again very important and interesting. Learning about the fetoplacental insufficiency by color flow and growth chart are very important. And to throw light on this very important topic, we have Secretary General of National ISOPARB, Dr. Pragya Mishra Chaudhary with us. And to chair this very important session, we have, I welcome Dr. Madhavi Mittal ma'am, who is a learned consultant endocrinologist from the city of Prayagraj. Dr. Madhavi Mittal ma'am has nurtured and changed the ultrasound diagnosis in our city. She is very, very academically oriented with more than 30 years of experience. Her area of interest are women imaging and fetal medicine. Welcome, ma'am. And I would like to invite Dr. Gitanjali Kaur. She is President, Ludhiana Obstetrics and Gynecological Society. She has more than 24 years of clinical experience. She had been organizing secretary of the North Zone Yuva FOGSI, which was held in 2022. And she's a speaker and chairperson in various conferences. Welcome, Dr. Gitanjali. And I would request Dr. Gitanjali to kindly introduce our speaker for the next session, Dr. Pragya Mishra Chaudhary. Over to Dr. Gitanjali and the chairpersons.
Good evening, everyone. I bring greetings from Ludhiana, and I thank Dr. Ranjana and Dr. Amita Tripathi for involving our Ludhiana society. Dr. Ranjana Khanna has already introduced the subject, and we will move forward with our discussion on color flow and growth charts, because all of us know that as obstetrician, the onus lies on us to deliver the baby at the right time. First is to identify and then planning the delivery, because it is too earlier delivery can lead to iatrogenic prematurity, while too later delivery can make a womb becomes a tomb for the fetus. All of us know that unexplained stillbirth, when we look at unexplained stillbirth, more than 50% of them are FGR babies. So it is very important for us as obstetrician either to do our own Doppler or to know how to read the waves. The color Doppler waves, we should know how to read the waves. PI values has made it much simpler, and we have none other than Dr. Pragya Mishra Chaudhary from who's going to talk about this subject. Madam is a keen academician with a lot of awards. She has special interest in fetal medicine. She's been past chairperson of the Genetic and Fetal Medicine Committee and also Secretary General of ISOPARB. She has lots of awards and has contributed chapters to a lot of books. I would like to invite her to give this talk.
Good evening to all of you. At the outset, I would like to thank Dr. Ranjana Khanna and team ISOPARB Prayagraj chapter and Dr. Amita Tripathi as well, so to have invited me for this webinar, which is jointly being organized by Ludhiana and correct me if I'm wrong, I think Jalandhar chapter of Obs and Gynae Society. So actually, you know, when today I'm feeling so nostalgic because my memories go back to 2017 when Dr. Rishma was the president of FOGSI, Dr. Ranjana Khanna was the vice president of FOGSI, and I was the chairperson of genetic and fetal medicine. And I still remember, having been involved by Dr. Ranjana Khanna about that conference. She was talking about BOH, the triology that was held in
Delhi.
in Gurgaon.
Delhi.
So feel
Yeah.
really nice, and to have such esteemed chairpersons, who I know they are very much more learned than me when it comes to Doppler and fetal growth. So it's really nice, and thank you for the kind introduction also. So actually, Dr. Ranjana Khanna has made my job easy because obviously, well, she spoke on prevention and management of FGR. And management of FGR cannot be done without Doppler. And my topic is the role of Doppler and growth charts in managing. So if there are some overlaps, please pardon me for that. So, until quite recently, there was this, there was no consensus regarding the definition of fetal growth restriction until 2016, when this international expert panel, they came up with the consensus criteria for FGR. And this was called the Delphi consensus criteria, where and the criteria for FGR in this was that a very small fetus with abdominal circumference or estimated fetal weight of less than 3rd percentile, or a small fetus with abdominal circumference or estimated fetal weight less than the 10th percentile, with additional abnormal Doppler findings, or a decrease in abdominal circumference or estimated fetal weight by 2 quartiles or more. So according to this international Delphi consensus, there were criteria for early FGR and late FGR. So early FGR, where the line of demarcation was 32 weeks. So under that, so you would call it early FGR, and late would be equal to or greater than 32 weeks. So the criteria for early FGR were that either AC or estimated fetal weight less than the 3rd centile, or umbilical artery with the absent end diastolic flow. Or otherwise, you could have abdominal circumference, estimated fetal weight less than the 10th centile, but it should be combined with uterine artery PI greater than 95th centile, and or umbilical artery PI greater than 95th centile. So, and with late FGR, where the gestational age is more than 32 weeks, there the criteria would be, well, abdominal circumference, estimated fetal weight less than the 3rd centile, or at least 2 out of the 3 of the following. So 2 out of the 3 would be abdominal circumference, estimated fetal weight less than the 10th centile, or abdominal circumference, estimated fetal weight crossing centiles, which is greater than 2 quartiles on growth centiles, or cerebral placental ratio of less than the 5th centile, or umbilical artery PI greater than the 95th centile. So these were some of the criteria through which, they divided, how to base early and late FGR on. So as you can see on this growth chart, on A, what you can see that, well, the baby is growing, the growth is at about the 50th centile. On the right hand side, what you can see that the baby's growth is actually below the 3rd centile over here. So definitely, but this baby is still growing, but the growth is below the 3rd centile. So having the growth below the 3rd centile in itself, is actually one of the criteria for FGR. And, on the graph C, what you can see that, it is a case of late onset FGR, where initially the baby's growth was at the 50th centile, then late towards the 3rd trimester, then the baby's growth is actually, tailing down, and it has come down to below the 3rd centile. And, and on D, what you can see that initially it was, the growth was fine, But later on, it dropped down to the 50th, and then again it dropped down to the third centile. So that you would call it a case of relative FGR. So which growth chart to use? Well, Dr. Ranjana Khanna had mentioned, but it was there in my topic. So we have population-based universal charts like Hadlock, Intergrowth 21st, WHO, and you have local and customized charts. So Intergrowth 21st, well, it's a multiracial, based on multinational methodology is sound, and it complements the WHO growth charts. And the customized growth charts, these are the ones where you adjust for maternal weight, height, parity, and ethnicity. It is a better predictor for FGR and FGR related problems. However, even Dr. Khanna mentioned the same. However, the problem is that it is difficult to obtain. So, we need to know the main differences between early and late onset forms of FGR before we talk about the role of Doppler in FGR. Now, as you can see, that early onset FGR, which comprises only 1 to 2% of FGRs, the problem is with management. The placental disease is severe. Umbilical artery Doppler is abnormal, and it has a high association. Early FGR has a high association with preeclampsia. Now, then the hypoxia. Then there is hypoxia, which leads to systemic cardiovascular adaptation. And the immature fetus, however, has a higher tolerance to hypoxia, and the mortality rate and morbidity rate is very high, but it has a lower prevalence compared to late FGR, and it comprises about 20 to 30% of the total percentage of FGR cases. With late onset FGRs, the problem is with diagnosis. The placental disease is mild, and umbilical artery Doppler could be normal, and it has a low association with preeclampsia. There could be hypoxia, or there may not be. There is leading to central cardiovascular adaptation. And the difference is that the mature fetus has a lower tolerance to hypoxia, and there is the mortality rate is lower compared to early FGR, but it is a common cause of late stillbirth and affects a large percentage of FGR cases, almost 60 to 70% of the cases. Now, with what is this Doppler effect? Now, there is a change in the apparent frequency due to relative, basically, what happens that when the sound wave strikes a moving target, just like the blood vessel, the frequency of sound waves reflected back is proportionate to the velocity and direction of a moving object. And it is used to determine the volume and rate of blood flow through the vessels. You can see, that this moving blood vessel, and when the sound waves, they fall on the moving blood vessels. Now, these sound waves are reflected back depending on the velocity and the volume of the flow of the blood vessels. Now, what happens that, when we talk about Doppler, we always say that angle of insonation should be close to 0. And that is, between the Doppler beam and the direction of flow. Because what happens that higher the angle, lesser the frequency, and there will be more error. As you can see that, if these sound waves fall on different angles to these blood vessels, what is happening that, with the rise of the angle, the frequency also changes. And because of that, we can get erroneous results. It's quite nicely depicted in this, picture. So to minimize error, that is the reason we use ratios. And where, we are not worried about these angles at which, the sound waves are falling onto the blood vessels. So, and these indices that we have are like systolic to diastolic ratio, which means the peak systolic flow divided by the end diastolic flow. Then we have the pulsatility index, which is the systolic minus diastolic upon the mean of the two, and resistance index, which is S minus D upon systolic flow velocity. So most popular and what is most commonly used nowadays is the pulsatility index in Doppler. So again, as we can see, you can see the just a pictorial representation of the peak systolic velocity and the end diastolic velocity, and you have the average of the systolic and the diastolic. All these are actually depicted in this picture. So what is the role of Doppler in fetal growth restriction? It is to identify the etiology of fetal growth restriction, whether it is placental or it's non-placental, then to identify hypoxia and fetal adaptation, to plan the timing of the delivery, and to identify fetuses at risk of perinatal complications. So basically, we want to know whether the resistance it's a vascular bed resistance, and to know that, which means you have to study the Doppler of uterine artery and umbilical artery to identify fetal adaptation. We study the Doppler of the middle cerebral artery, and to identify cardiac decompensation, we have ductus venosus, umbilical vein. So basically these are the vessels, broadly, that we study in FGR Doppler. So there was a Doppler meta-analysis which had shown that the use of umbilical artery Doppler reduces the number of antenatal admissions by 44%, inductions of labor by 29%, and cesarean sections for non-reassuring fetal status by 52%, and the overall perinatal mortality by 38%. So the Doppler vessels which are studied on the maternal side are uterine artery Doppler. On the placental side, we have the umbilical artery Doppler, and on the fetal side, we have the middle cerebral artery, aortic isthmus, and we have the ductus venosus, hepatic vein, umbilical vein Dopplers. So what uterine artery Doppler, Dr. Ranjana Khanna did talk a little bit. So its main use is in screening, and the early diastolic notch in the uterine artery, which you can see even at 12 to 14 weeks, it suggests the delayed trophoblastic invasion, which means that there is impedance to the flow in the placental bed, and this persistence of bilateral notch beyond 24 weeks confirms and indicates an increased risk of preeclampsia, placental abruption, and early onset FGR. An increase in impedance of flow in uterine artery at 16 to 20 weeks was predictive of superimposed preeclampsia developing in women with chronic hypertension. Now, this is a pictorial representation of the placental circulation. The blood supply to the uterus, as you know, is from the uterine artery, and then then you have the branches of the arcuates and the radial arteries and the basal arteries and the spiral arteries, which actually which invade the intervillous space, and that's how the blood supply to the the fetus gets the blood supply to the placenta. So as you know, I can skip this because we're already. So as the gestation increases, the diastolic flow velocities also should increase as the pregnancy as the pregnancy progresses. And what you can see that even PI of the uterine artery has to be it has to be plotted in a centile chart, like as ideally as the gestation increases, the PI of the uterine artery should actually fall, because so that there is improved uteroplacental perfusion. So whereas in FGR, what happens that the PI of the uterine artery increases, and it could be greater than the 95th centile. So there are some recommendations from the Royal College regarding uterine artery Doppler, that in high-risk populations, uterine artery Doppler at 20 to 24 weeks of pregnancy has a moderate predictive value for a severely SGA neonate. And in women with an abnormal uterine artery Doppler at 20 to 24 weeks of pregnancy, subsequent normalization of flow velocity indices is still associated with an increased risk of an SGA neonate. So repeating uterine artery Doppler is therefore of limited value. And women with an abnormal uterine artery Doppler at 20 to 24 weeks, which is defined as I just mentioned, a pulsatility index of greater than the 95th centile and or notching should be referred for serial ultrasound measurement of fetal size and assessment of fetal well-being with umbilical artery Doppler commencing at 26 to 28 weeks of pregnancy. And women with a normal uterine artery Doppler do not require serial measurement of fetal size and serial assessment of well-being with umbilical artery Doppler unless they develop specific pregnancy complications, for example, APH or hypertension. However, they should be offered a scan for fetal size and umbilical artery Doppler during the third trimester, which is again an issue for debate, because some people say you should do it at 34 weeks, some people would say 34, or some people would say 36 weeks. Coming to umbilical artery Doppler, it is the only measure that provides both diagnostic and prognostic information for the management of fetal growth restriction. On the one hand, increased umbilical artery Doppler PI has a great clinical value for the identification of FGR alone or combined with the cerebroplacental ratio. On the other hand, the progression of umbilical artery Doppler patterns to absent or reverse end diastolic flow correlates with the risks of injury or death. When umbilical artery Doppler are incorporated into management algorithm of growth restricted fetus, perinatal death is reduced as much as 29%. And umbilical artery Doppler becomes abnormal when at least 30% of the fetal villus structure is abnormal. And in extreme cases of growth restriction, end diastolic flow may become absent or there could be reversed end diastolic flow. So absent or reversed end diastolic flow occurs when 60 to 70% of the fetal villus structure is abnormal, and about half of the cases of absent or reversed end diastolic flow are associated with aneuploidy or a major anomaly. And absent or reversed end diastolic velocities, which is the end of the spectrum of the abnormalities of the umbilical artery Doppler, have been reported to be present on an average 1 week before the acute deterioration. And there is an association between reversed end diastolic flow in the umbilical artery and adverse perinatal outcome with a sensitivity and specificity of about 60%, which seems to be independent of prematurity. So as you can see in this Doppler report, that the amount of flow during diastole increases as gestation advances. Thus, what happens that the SD ratio and the PI decreases. Whereas, if there is a case of FGR, that wouldn't happen and the PI would actually increase. So again, as you look at this, again, umbilical artery PI should be plotted on centile graphs, and the PI value should actually go down as the gestation advances. So look at these some patterns of abnormal umbilical artery waveform. Here, there is actually the resistance index and the SD ratio and PI is increasing because of the following end diastolic flow. And in this, what we find in this report, that there is absent end diastolic flow of the umbilical artery. You cannot see that there is any flow during diastole. And here, the perinatal mortality rate can be very high, even up to 41%. So what happens that if this, from reduced to absent end diastolic flow, if with further deterioration, there can be reversal of the end diastolic flow, as you can see in this report, and the perinatal mortality rate can be even, it can be from 33% to 73%. So as you can see in this, on the top, what we can see, this is, it is a case of a normal umbilical artery Doppler. Then the second one, there is high resistance where there is reduced end diastolic flow. In the third picture, you can find there is absent end diastolic flow. And in the bottom, the bottom picture, we can find there is reversed end diastolic flow. So again, there are some recommendations from the ICOG with regards to umbilical artery Doppler. In a high-risk population, the use of umbilical artery Doppler has been shown to reduce perinatal morbidity and mortality. And umbilical artery Doppler should be the primary surveillance tool in the SGA fetus. When umbilical artery Doppler flow indices are normal, it is reasonable to repeat surveillance every 14 days, when more frequent Doppler surveillance may be appropriate in a severe SGA fetus, and when umbilical artery Doppler flow indices are abnormal, which means that the PI or RI is equal to or greater than 2 standard deviations above the mean, and delivery is not indicated, then in those cases, the surveillance has to be done twice a week if there is absent end-diastolic flow, or if there is a reversed end-diastolic flow, then we will have to do it almost on a daily basis. So coming to middle cerebral artery Doppler, middle cerebral artery PI less than the 5th centile is considered an early stage change of FGR, and the nadir of middle cerebral artery PI is reached 14 days or more before fetal compromise. But now, if there is normalization of the middle cerebral artery PI, then that is not a good sign, because the reversal of adaptation in growth restricted fetuses is considered a poor prognostic sign, because it is actually due to cerebral edema, and middle cerebral artery informs about the existence of brain vasodilatation, a surrogate marker of hypoxia. An abnormal middle cerebral artery PI had a 6-fold risk of emergency cesarean section for fetal distress when compared with SGA fetuses with normal MCA PI. An abnormal middle cerebral artery PI is associated with poor perinatal outcome at even greater than 2 years of the infant age. So basically, why there are changes in the middle cerebral artery? That is because of reflex redistribution of the fetal cardiac output. There is, in a case of FGR, there is a reduced as a mark of decompensation. The blood flow to the kidneys and the lungs, the gut, liver, muscle, body fat, glycogen stores, it goes down, leading to oliguria, oligohydramnias, RDS, NEC, FGR, and there is increased flow to the brain, heart, and the adrenals, which are the vital organs. So there, as you know, there is sometimes, what is very important that, that whenever, if your radiologist does not plot the PI values of any of these vessels, on the centile chart, and just gives you the value, you should ask him or her to actually graph where it has been plotted, so that whether the PI falls at the 5th centile or the 50th or the 95th, or it's greater. So that's very, very important. Okay. So this cerebroplacental ratio, which is a ratio of the middle cerebral artery pulsatility index to umbilical artery pulsatility index. Now, CPR is essentially a diagnostic index, and it is more sensitive. It is a more sensitive index for detecting poor perinatal outcome than umbilical artery or MCA Doppler alone. The CPR is already decreased when its individual components suffer mild changes, but are still within normal ranges. So abnormal cerebroplacental ratio predicts neurobehavioral problems at 18 months of age. So this cerebroplacental ratio, CPR, is even more sensitive than umbilical artery PI or middle cerebral artery PI together or separate. So the RCOG recommendations about the middle cerebral artery are that in the preterm SGA fetus, middle cerebral artery Doppler has limited accuracy to predict acidemia and adverse outcome, and should not be used to time delivery. And in the term SGA fetus with normal umbilical artery Doppler and abnormal middle cerebral artery Doppler, which is a PI of less than the 5th centile, has moderate predictive value for acidosis at birth and should be used to time delivery. Aortic isthmus Doppler, now this vessel reflects the balance between the impedance of the brain and systemic vascular systems, and it has a strong association with both adverse perinatal and neurological outcomes. And aortic isthmus precedes ductus venosus abnormalities by almost a week. So ductus venosus is the strongest single Doppler parameter to predict the short-term risk of fetal death in early onset FGR, and ductus venosus flow waveforms become abnormal only in advanced stages of fetal compromise, and there is a good correlation of abnormal ductus venosus waveform with late-stage acidemia at photosynthesis. and absent or reversed velocities during atrial contractions are associated with perinatal mortality independently of the gestational age at delivery, with a risk ranging from 40 to 100% in early onset FGR. And in about, I think Dr. Khanna had already mentioned about this, that in about 50% of cases, abnormal ductus venosus precedes the loss of short-term variability in computerized CTG. And in about 90% of the cases, it precedes the biophysical profiles by 48 to 72 hours almost. So this is a report of a patient showing the ductus venosus flow, which seems to be normal in this case. Yeah. Now, whereas there was a case of whereas, on the right-hand side, what we can see that the ductus venosus flow waveform is actually abnormal. On the left, it seems to be normal, and on the right, it is abnormal. Sorry. So, with regards to the recommendations by the RCOG about ductus venosus and umbilical vein, ductus venosus Doppler has moderate predictive value for acidemia and adverse outcome, and ductus venosus Doppler should be used for surveillance in the preterm SGA fetus with abnormal umbilical artery Doppler and used to term delivery. So what is the aim of monitoring? It is basically, we want to intervene. As we all know that there is no sure shot, treatment for FGR. So basically by timely intervention and monitoring, we can actually prevent FGR or prevent it from deteriorating. So monitoring of growth, detection of hypoxia, and detection of acidemia through Doppler, biophysical profile, CTG, and daily fetal movement counts. So how often is this monitoring done? Frequency is dictated by severity of growth restriction, gestational age of the fetus, and biometry should be done at least at 2 to 3 weeks interval. No value for biometry if interval is less than 2 weeks, and Dopplers 2 to 3 weeks if mild, and weekly, bi-weekly if there is severe, if it is a case of severe FGR. And so what is the timeline for fetal hypoxia? To start with, there is abnormal fetal growth, followed by abnormal arterial Doppler, which is umbilical artery, middle cerebral artery, which happens in about 2 weeks. Then an abnormal venous Doppler, which is inferior vena cava and ductus venosus, which can happen in a period of over 1 to 2 days, followed by abnormal the NST and biophysical profile score. So this is showing the sequential changes in FGR. To start with placental disease, we have compensated hypoxia, decompensated hypoxia, and finally death. And all the changes which I was talking about with regards to uterine artery Doppler, umbilical artery, how they occur in a sequential fashion in a case of FGR. So what is the optimal gestation to deliver the SGA fetus? In the preterm SGA fetus with umbilical artery absent or reversed and diastolic velocity detected prior to 32 weeks of gestation, delivery is recommended when ductus venosus Doppler becomes abnormal or umbilical vein pulsations appear, provided the fetus is considered viable and after completion of steroids. So this is, in a case of a preterm SGA, where where there's a problem with umbilical artery, then you want to buy some time, then we use the ductus venosus Doppler, which is very useful. And even when venous Doppler is normal, delivery is recommended by 32 weeks of gestation and should be considered between 30 to 32 weeks of gestation. If MCA Doppler is abnormal, the delivery should be recommended no later than 37 weeks of gestation. And in the SGA fetus detected after 32 weeks of gestation with an abnormal umbilical artery Doppler, delivery should be done no later than 37 weeks of gestation. And in the SGA fetus detected after 32 weeks of gestation with a normal umbilical artery Doppler, a senior obstetrician should be involved in determining the timing and mode of birth of these pregnancies, and delivery should be offered by 37 weeks of gestation. And so, and how should the SGA fetus be delivered? The recommendations are that actually I'm sort of, I think, exceeding what I think my topic was, but there is a little bit of overlap. That because in the SGA fetus with umbilical artery absent or reversed end diastolic flow, delivery by cesarean section is recommended. And in the SGA fetus with normal umbilical artery Doppler or with abnormal umbilical artery PI, but end diastolic velocity is present, induction of labor can be offered, but rates of emergency cesarean section are increased, and continuous fetal heart rate monitoring is recommended from the onset of uterine contraction. So there is so what about the so basically to sum up, the optimal method and frequency of fetal surveillance in a SGA infant and the optimal tests or test to time delivery, we have this very nice stage-based classification and management of FGR. As you can see that the 4 stages, the first stage where there is mild placental insufficiency, and the criteria is EFW less than the 3rd centile, CPR less than the 5th centile, umbilical artery PI and greater than the 95th centile, uterine artery PI greater than 95th, and MCA PI less than the 5th centile. So monitoring should be done weekly, and one can go ahead with labor induction at 37 weeks in cases of mild placental insufficiency. When then in stage 2, where there is in a case of severe placental insufficiency, where the criteria is umbilical artery with absent end diastolic flow or a reversed flow in the aortic isthmus, monitoring should be done bi-weekly, and delivery should be carried out by 34 weeks, and through cesarean, it should be a cesarean delivery. And in stage 3 FGR, where there is low suspicion of fetal acidosis, but there is fetal acidosis, so umbilical artery is there is a reversed end diastolic flow, and ductus venosus PI is above the 95th centile. Monitoring should be done every 1 to 2 days, and delivery should be the fetus should be delivered by 30 weeks through a cesarean delivery. And in cases of stage 4 FGR with high suspicion of fetal acidosis, where the criteria are ductal with reverse flow A wave in the ductus venosus, computerized CTG with short-term variability, and fetal heart rate decelerations, monitoring should be done 12-hourly, and the fetus should be delivered by 26 weeks through a cesarean section. So basically, the management algorithm depends heavily on gestational age and Doppler changes. So we have to really, we have to weigh the risks of prematurity, where there is where if you deliver, then the baby is subjected to a difficult extra-uterine environment. So, and you have to weigh to a fetally growth-restricted baby, where there is a hostile intrauterine environment. So we really have to weigh these 2 things. And Doppler in today's era, we just cannot manage fetal growth restriction without Doppler. And so the role of, and so Doppler and growth charts play a pivotal role in the management of FGR. And it's very important to use these centile graphs. No point in just getting the values, because they have to be plotted. Only then you can say whether the baby is growing or whether the PI is rising or it's going down. So it's really important, the 2 things, the growth charts and the Doppler in management of both early and late FGR. And these days, one thing I just want to emphasize, that it's the days are gone where we used to talk about, asymmetrical and asymmetrical. So I think that brings me to the end of my talk, and I would just like to end up saying that miniatures are joy to collect, but in life, growth matters. So really, well, we don't want the fetally growth restricted babies. So it's high time to act upon them and to
Thank you, Dr. Pragya. That was a very comprehensive and lucid talk on the role of Doppler ultrasound and ultrasound in FGR. I also would like to thank ISOPARB Prayagraj for making me a part of this very important webinar. Dr. Pragya, I'm glad you have covered the topic so well. You have given us a lot of gyan, I think. Most importantly, you have mentioned the criteria for defining FGR. And also you have highlighted that in the early onset FGR, which was earlier used to be called the symmetric FGR, but it's now called early onset FGR. The problem in this is management, because you have to balance between timing the delivery to get a premature baby, or you allow the fetus to deteriorate in utero. Whereas in late FGR, the problem is mainly diagnostic, because you may not be able to detect that this is an SGA fetus with normal Doppler, and this is likely to progress to a late onset FGR. And these fetuses have low tolerance to hypoxia, and therefore they're more likely to end up as IUD or stillbirth. And in these late FGR fetuses, these are the ones where you may get a normal umbilical artery. And so you have to rely on primarily the cerebroplacental ratio. And nowadays, they even consider that the uterine artery also has a role to play in identifying these fetuses. Of course, it will not be a trigger for delivery, but it is a role in identifying. And also the role of Doppler in FGR has covered in terms of the vascular bed, like the placental bed would be covered by the uterine artery and the umbilical artery. The fetal adaptation part of it, where the fetal redistributes its blood flow to give more flow to the vital organs, that we come to know by the MCA, cerebral artery. And if the fetus is in really a bad stage and the heart is decompensating, then that will come to know by the ductus venosus. So these are the three main parameters where we come to know what is the state of the fetus. And also, you have mentioned that there is no point repeating biometry before an interval of 2 weeks, because you are not, that information is not going to really guide you. You have to wait for a minimum of 2 weeks to be able to assess the growth. And summing up, all in all, you can just say that as long as the umbilical artery shows a positive diastolic flow, in other words, it is not end diastolic or reversed absent end or reverse diastolic flow. As long as the flow is positive, you can try to take the pregnancy to 37 weeks. And then in that case, it is not necessary that you have to do a cesarean. You can go for labor induction if the other parameters allow that. But in all other cases where you have absent or reversed umbilical flow or ductus venosus, which is abnormal, you have to deliver definitely at the latest by 34 weeks or earlier, and you need to do a cesarean. You don't have any options beyond that. So thank you, Dr. Pragya. That was a very well conducted.
Very nice talk. Very nice talk, Pragya.
Thank you so much.
Yeah.
Thank you,
There
Pragya.
were some controversies in the sense that the Society of Maternal Fetal Medicine of the American College, what they say, their recommendations are that base your management totally on umbilical artery, Doppler. I mean, what they are saying that do not base your management on a middle cerebral artery or ductus venosus or or umbilical vein pulsations. They have strictly said no. But I mean, but they have simplified the management also. Maybe it may be a good. Those recommendations would be good for the general obstetrician, to follow. So I would recommend, people going through the Society of Maternal Fetal Medicine of the American College guidelines, which are just based on this, where they have not given any, they have just given weightage to umbilical artery Doppler.
Actually, the ISOG guidelines are saying, and even the Fetal Maternal Medicine Foundation, all of them say that in late FGR, your umbilical artery Dopplers are likely to be normal. And again, that is why you would be missing the diagnosis of late FGR if you go by just the umbilical artery. So you have to make a judgment call on what you are going to follow. And also there is a controversy, not really a controversy, the latest guidelines also say that the notching of the uterine artery is actually not being considered any longer as of any prognosticator significance. They just say that you go by the mean uterine artery PI and just take that value as the single prognosticator.
So any questions do we have, Dr. Parul?
Yes, ma'am. There's one question for Dr. Pragya, ma'am. At what gestational age should the first Doppler be done in a high-risk patient?
If in a high-risk patient, I think I would recommend. So see, whenever you're doing a Doppler, you should do a growth scan also. So at least by 26 to 28 weeks, you should do growth scan and a Doppler in a high-risk patient.
Yeah.
Basically, I think it would be that when the fetus has reached an age of viability, where you have an option of delivering the baby and getting a live baby, that is when you should start doing the Dopplers.
True.
And the low risk ones, you can wait till the third trimester.
Yeah.
Low risk.
Definitely.
Ma'am, but nowadays Doppler is also done at even at 11 weeks or 20 weeks just to assess the parameters in high-risk patients, especially like at the time of NT scan also, and a Doppler is done at the time of 20 weeks, like a TIFA, then also Doppler is done to identify the risk in subsequent pregnancy also. So what would you say about that?
No, but that is mainly, uterine artery Doppler. What they are doing, at the time of, EFTS, which is, extended first trimester scan. So along with the biochemical markers like PAP-APE, serum beta HCG, PLGF, they are doing uterine artery Doppler. Because you can tell, along with mean arterial blood pressure and uterine artery PI, you can tell, whether this patient has a risk of preeclampsia before 34 weeks or before 37 weeks. So that's the main idea of doing Doppler at that time, because you want to assign a risk for preeclampsia later on in pregnancy.
Okay. Then there is a question for Dr. Ranjana, ma'am. What is the role of fetal kick count in low resource settings?
In low resource settings, of course, kick count has got a lot of importance, because if you can do that, then you don't have to, and low resource settings, you don't have any other alternatives. So I think DFMC is very important in those settings.
There's another question. Any study on role of eating raw beetroots to increase nitric oxide for fetal growth restricted fetuses?
Yeah, actually some studies have actually been done, and they do say that beetroot juice does have some nitrate or something, and that will improve the placental circulation, and it will help in preventing hypertension. How far it's true, I don't know, but studies are being done, and there has been found to be a role of beetroot. So we can offer that to the patients. No harm.
So
thank you, ma'am. These are the questions for.
Thank you, Pragya ma'am, for this very informative and talk in a very simplified way. And thank you, chairpersons. And now we have delivered the baby, and we are giving this baby to the neonatologist. And I would ask again to Parul, Communicator, ISOPARB Prayagraj, to start the session.
Good evening, respected faculty and delegates. Now we move on to our third session, which is basic management of fetal growth restricted babies. I would like to now invite our esteemed chairpersons for the session. Our first chairperson is Dr. Ishita Banerjee. She is consultant pediatrician, Allahabad, fellow Indian Academy of Echocardiography. She is also a PG diploma in clinical echocardiography. Ma'am has also done LLB with the PG diploma in medical law and ethics. Her special interests are pediatric cardiology, fetal echocardiography, and she aims to sensitize private practitioners towards the treatability of congenital heart diseases through early diagnosis and timely referral. I welcome you, ma'am. Our second chairperson is Dr. Ritu Gupta. She is currently NICU PICU in charge at Preeti Medical Research and Charitable Trust, Allahabad. Faculty for PALS. Ma'am has several publications in various journals, including Lancet, Journal of Indian Academy Pediatrics, Journal of National Neonatology Forum. Her special interests are pediatric nutrition. Welcome, ma'am. I now request Dr. Ritu Gupta, ma'am, to introduce our speaker, Dr. Piyali Bhattacharya, ma'am. She is consultant pediatrician, SGPGI MS, Lucknow. We will be speaking on basic management of FGR babies. Over to you, Ritu, ma'am.
Thank you so much. Thank you, Dr. Amita, ma'am, Dr. Ranjana, ma'am, for making me a part of this. I'm feeling immense honor in introducing Dr. Piyali Bhattacharya. Ma'am has been a source of inspiration to many of her colleagues and new pediatricians alike. She's an extremely knowledgeable person, and she also aims to impart her knowledge to others through her teachings. She has been taking up a lot of programs of national importance like National Tuberculosis Elimination Program, National Neonatal Resuscitation Program, Pediatric Advanced Life Support Program. She has had many publications and awards to her credit and has authored IAP textbook of vaccination. At present, she is a consultant pediatrician at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. She would speak on basic management of fetal growth retarded babies. Welcome you, ma'am.
Thank you so much for that introduction, Ritu. It's so nice to see a galaxy of speakers. Ranjana ma'am here and Amita here, all friends, Parul. Thank you for inviting me, organizers. I would like to share my screen. You know, somebody was saying the other day that, you know, motherhood is the greatest thing. But of course, it happens to be the hardest of things. So when we say motherhood and babies, you remember it is difficult, but it is a pleasure for all of us. Those who are mothers would identify with me. So thank you all. Let me start with saying that the definition of FGR is really, really difficult. You know, it is very difficult because the term is used to describe a fetus which has not reached its growth potential because of so many factors. You know, the factors could be fetal, the factors could be placental, the factors could be maternal, but again, there's a significant overlap amongst these entities. So we have based our definition on gestational age or abdominal circumference, which is less than 10th percentile for that age. However, other definitions have already been proposed. Now, when we talk about fetal growth restriction, remember, not all small, we basically found our definition on growth, on restriction of growth or on a small baby. But remember, not all SGA babies are growth restricted. And conversely, not all FGR infants are SGA. I've shown you three pictures over here. The first is a normal term infant. The second is the small for gestational age baby. And you can see the proportionate decrease. However, it is lesser in weight. And the third is an FGR baby, where you can see the disproportionate growth of the head to the torso. So that is why I'm saying that SGA babies may be small, but not always at increased risk of adverse potentials. You know, if they are, they could be constitutionally small as well. This is one slide which Dr. Ranjana has already shown. And I would like to say that in India, you know, globally, if we take the statistics, there are about 20 million low birth weights. And if FGR is taken, it is one of the prominent causes of low birth weight in developing nations. So if we say low birth weight, remember 60% of these low birth weights are term FGRs and 40% of the remaining are premature. Do remember that it could be a term FGR and you have carried on the pregnancy being a very good obstetric specialist, or you are forced into delivering early and the child comes to you as a preterm baby. So when we talk about the appearance, remember all of you have witnessed, this is an extreme case, but a little bit of each of these things may be present in these babies. You know, once the nutrient supply is compromised, overall the size will be decreased and the child will try to preserve the brain growth. So total body fat, total lean mass, the bone growth, all these will be reduced. And what will happen? The appearance will be like this. That is a wasted, wizened appearance. So when you look at the cranial sutures, you know, these cranial sutures are all widened. The anterior fontanelle is larger than expected, and the head will be relatively larger than the torso in size. And in many of them, you will find long nails, a scaphoid abdomen, and along with that, you may find meconium staining as well. When we talk about the complications, there are multitude of complications in these babies. So I've listed all of them and a few which I have marked over here, like asphyxia, thermoregulation, hypoglycemia, PPHN, infections, and we will discuss these things as I proceed. So the most important thing, as everybody has pointed out, is actually the timing of delivery. That is the best treatment that we can give, and that is the best management that we can give to these babies. So when I talk about the management outline briefly, we will talk about the care at delivery. We will talk about temperature maintenance, managing a glycemic control and asphyxia or apnea or RDS, and prevention of infections, a little bit on the nutrient and some supportive measures. Please remember there is a special care group. The junior most of these FGR babies will have inability to suckle, inability to swallow. So feeding is a very risky thing for us. Almost all of them have inability of temperature control, and many of them will have inability to control cardiorespiratory functions without cyanosis. So this special care group has to be delivered in the it has to be kept in the NICU, and utmost care needs to be taken. So at delivery, when we are talking just at delivery, as everybody pointed out, should be at a good center, and the clamp should be cut quickly to prevent hypovolemia, hyperbilirubinemia, and if required, the cord length should be kept a little longer, may 10 centimeters rather than just 5, because we may need an exchange transfusion in cases of hyperbilirubinemia and sometimes in cases of polycythemia as well. So the physical examination, a quick look through, accurate measurement of length, weight, and head circumference. I'll just point out why. And this is all required actually for accurate adjustment of the gestational age. Now, everybody has pointed out to so many charts, International 21, WHO charts, but this is Fenton's and Olson's charts. These are for preterms, you know, where again, we use the head circumference, the height, and the length for assessment of the prematurity of these children. Now, let us talk a little on hypothermia, you know. The sequel of hypothermia, everybody's been talking about arterial blood gases. This is a bad thing to happen. Those children who go from hypoxia to hypoglycemia and then to anaerobic metabolism and metabolic acidosis have a bad prognostic outlook. So remember, we have to prevent hypothermia at all causes, because if you remember, they are deficient in thermoregulation because their subcutaneous fat is low, their brown fat is low, their ability to thermoregulate is again low. So when they are born, we talk about not all resuscitation is ABC, airway, breathing, and circulation. We talk about T, which comes right in front of ABC, and thermoregulation is of utmost importance if all the obstetricians would help with that, it would save many a child. So the delivery room temperature, when you go into the delivery room, we should shut out all the draughts from the windows, from the doors. And I know it is a little difficult for the obstetrician, but the AC must be put off. If the child is delivered there, the child will lose thermoregulation. So all physics principles over here, evaporation, radiation, all of that physics we read, the child loses the heat because of that. So delivery room temperature, ideally there should be a thermostat over there, and it should be greater than 26 degrees centigrade. The baby corner should be higher than 32 degrees centigrade, and the baby should be dried. I would again say not cleaned. The baby should be dried and the wet towel removed immediately to prevent heat losses. Now the baby is quickly, cord is cut, the mother is counseled, and the baby is shifted to a radiant warmer or an incubator. In extremely preterm babies who are of low birth weight, a lot of preemies, what we do is we use cling wraps. जो हम लोग food grade cling wraps खाने में use करते हैं, we use the same thing, or we use food grade plastic bags. We cut a neck into them and slip the baby inside. What is very important here is that we don't waste time drying the baby. We just put the cling wrap and shift the child to a radiant warmer or an incubator. And for those babies who are thermodynamically stable, I would ask all of us to do a KMC. If the mother is not stable, of course, the father can do it, the grandmother can do it, the nanad can do it. So anybody from the family can be inducted into a KMC protocol. Next, let's talk about infections. So when we talk about infections, remember, a lot of infection, we are giving the child, those who stay, they will get nosocomial infections. A lot of infection introduced through a lot of handling, a lot of invasive procedures. So remember, hand washing and hand washing and hand washing. Every baby for 2 minutes, and then baby to baby for 20 seconds hand washing is a must. Avoid unnecessary use of antibiotics because they will give further infections to the child. We can even have fungal ones. So still today we start with the protocol of Ampigenta, and then we go on to whatever the culture growths come to us. Talking about the nutrition part. Now this is very, very important. The enteral feeding is started, and this is based upon the gestational age, the birth weight, the postnatal age, and the feeding effort of the baby. So not all babies will be able to suckle and swallow. We need to see if the suckle-swallow reflex is there. Some babies can be, if they are above 34 weeks, we all know they can be breastfed. Otherwise, you can use a Paladay, or you can do a gavach feeding, or you can start parenteral nutrition. And remember, all 4 types, the colostrum, the foremilk, the hind milk, and preterm milk are all very important, and they should be given either through breastfeeding or expressed and given by Paladay or gavach feeding. And of course, if we fail to establish, then only we go for parenteral nutrition. Now, I've given this chart. The chart shows what is to be done and when is to be done. So the first thing is at 28 weeks, if it is less than 28 weeks, remember, straight away go for IV fluids. However, if it is the birth gestational age is a little higher, that is 31 weeks, try to start NG feeding, observe if there is abdominal distension, if there is vomiting, and then you go for a gastric tube feeding. If it is 32 to 34 weeks, remember, start feeds with spoon or Paladay. And then remember, if the child is accepting well, able to do adequate amounts, then continue with Paladay feeding, say for the first 7 days or so. And as soon as possible, initiate breastfeeding in these children so that the positioning, attachment, everything is supervised and well attained, and they are able to suckle effectively. So breastfeeding, you keep on counseling the mother every day that she would need to breastfeed. So many a mother would mentally become prepared. Sometimes we even allow a lot of non-nutritive sucking if the child is able to do it. So again, this is the time frame, how you are doing it. Infants on spoon and Paladay can be actually converted to infants on sometimes from RT feeding and IV. we can go to OG tube and then finally to spoon feeding. So taper and stop spoon feeding once the mother is all right and confident. So as I said, you will be counseling the mother repeatedly. Once you are tapering off the fluids, you need to go on at 32 weeks to spoon feed. And if child is not accepting, then you need to continue with OG feeding. Now, this is the time frame about what the child has to be done. First, feed on day 1, the breastfeeding, or if the child is lower than that, day. If the child is even lesser than that, maybe 30 ml per kg of NG feeds. If not accepting, then we'll have to go for IV feeds. And less than 28 weeks, remember, we need to give trophic feeds or parental nutrition. Now, increments again, 30 to 35 ml per kg per day. And the little ones will take just half of that, 10 to 15 ml per kg per day. So the total maximum feed will be about 200 ml per kg per day once feeding has been established. The intervals could be between 2 hours to 4 hours. And in the extremely low 28 weeker, we may have to start IPN, TPN, or we have to go for EBM, or we may have to do IV fluids totally. So again, when I say IV fluids, remember, day 1 is just 10% dextrose, no sodiums, no potassiums. Day 2, again, we can think of sodiums. And day 3, if the child has passed urine, then of course we add on potassium as well. So first day is just everything free. It's just 10% dextrose. Now, when we talk about supplements, remember, we have to give vitamin K at birth to prevent any hemorrhage, because these children are particularly prone to hemorrhage. And vitamin D universally being added 400 IU every day till 1 year of age. Iron 2 to 3 milligrams per kg per day in 2 divided doses from 2 weeks of age. And sometimes in extreme preemies, we may need human milk fortifiers till the weight of 2 kilograms is reached. Now, the supportive measures are the most important part of management. So managing hypoglycemia, sometimes we may need to monitor repeatedly and actually give the child 10% dextrose. Remember, we do not prefer to give 25% dextrose because there is always a chance of IVH, that is intraventricular hemorrhage, if you are giving them 25%. So the routine procedure that we use is 10% for hypoglycemia. And then, of course, hypocalcemia monitoring, because these children do go into hypocalcemia, hypokalemia. So it is very, very important to monitor the fluids and electrolytes. So as I said, day 1, 10% dextrose, 60 to 80 ml per kg as per the birth weight, and increments of 15 ml per kg till day 7. And then we reach about 150 ml per kg per day. And then on the 3rd day or so, 2nd day or so, we add sodiums, and the 3rd day we add sodiums and potassium. Both are added after 48 hours for the fluid electrolyte management. Talking about the hemodynamics, remember, the mean arterial pressure should approximate the gestational age in weeks. How do we monitor that? Of course, we have a lot of monitors presently, electrical gadgets, but clinical, as Dr. Ranjana was saying, clinically, we always try to monitor these things. So the color of the child, the CFT, the urine output will help us in monitoring these children, and hemodynamic support should be maintained along with these. So what would we do if the child is hemodynamically not doing well? Remember, the treatment is bolus. We go slow because their acceptance is less. So we go very slow, over half an hour to 1 hour. We give 10 ml per kg of normal saline bolus. And at times, of course, if they are hemodynamically unstable, we may need inotropes always. So sometimes. So aim is basically to maintain the main arterial pressure above the gestational age of the neonate in weeks. And as Dr. Ipshita is doing echos, so thank you so much for doing functional echos, which is a very, very promising tool to monitor the hemodynamic status once you have given a volume of 10 ml per kg NS, or you have given the inotropes to see the responses. It is important to do a functional echo. Now, for PDAs which are often found or may actually open up in response to asphyxial stress. We use oral ibuprofen, and paracetamol and ibuprofen have been found to be as good as any other medication. Then oxygen. Of course, remember, oxygen therapy is a medication and we must treat with caution, and we must be guided with a pulse ox, which would say an SpO2 of 90 to 95% is very, very good and appropriate for us. Don't go for 100% SpO2 because that may again create problems. A little bit of the drive may help the child respire well. And then again, surfactants have come up. We have very good surfactants, which are usually given within an hour of birth if there is RDS and monitored by the down score. Now, regular temperature and vital monitoring, the respiratory rate, the heart rate, the CFT, the mean arterial pressure, and of course, the new vital which has come up is pulse oximetry. COVID has really taught us that pulse oximetry, how important it is. Avoid excessive handling. In our neonatal setup, we cocoon the baby in a sheet as if the child is in the mother's womb. We avoid bright lights or excessive handling. And at the present moment, the American Heart Association says that even in neonatal resuscitation, do not do any suctioning if it is not required. So excessive handling, avoid. Bright lights, avoid. Sounds at high decibels, avoid. You can have a very soft music in your nursery, which would actually help in growth. It has been found that the children like a soft music kind of a thing. Again, when you are doing procedures, remember, you must cluster all the painful procedures together so that one go you finish off. Repeated pricking, repeated pinching, that is not done. So remember, cluster the painful procedures together, and if required, give appropriate analgesia. Again, for future evaluation, for further evaluation, once a child is out of the nursery, look for any dysmorphic features. If you find dysmorphic features, these are indicative of chromosomal anomaly or any syndromes. So you will need the geneticist's help for that. Again, consider the exposure of prenatal drugs or toxins, which have to be considered. If you need any sort of counteract these, again, you have to know the prenatal history. And there are some congenital infections which will cause FGR, but the clinical signs may not be obvious. For example, cytomegalo. So you need to send appropriate serological testing or urine samples for these congenital infections as well. When you plan discharge, remember, you have to discuss with the parents, and there should be a multidisciplinary approach. So multidisciplinary, I mean, if you need a geneticist, if you need a lactation consultant, if you need a gynecologist, because the first contact is with the obstetrician, and she would be a pillar of support to you if you are actually going to discharge the patient and advising the patient in her presence. So it should be a multidisciplinary team, again, because you need an ophthalmologist for ROP, you need to check on the hearing, so you need the ENT specialist. So you rope in all of them if you are in a center. And then remember, weight is not the only criterion. It should be actually not be discharging babies weighing less than 2 kgs. Now, for babies who are less than 2 kgs, discharge can be considered when the baby is hemodynamically, physiologically stable. In fact, the baby should be able to maintain its own temperature in an open cot. And feeding is progressing well. The mother is not complaining. Doodh nahi pita hai, pakadta nahi hai. All those problems have been subverted and the parents can sufficiently care. Again, weight is one of the criterion that if there is greater than or equal to 30 grams per day, this child can be discharged along with proper feeding, along with physiological stability, and a generally healthy, happy, smiling baby. Now, prior to discharge, the parents' education is very, very important because they will go home and they will feed with a bottle. So most of them will think that if bottle feeding is given, the child will grow well. So nutritional and feeding requirements need to be explained, that mother's milk is the best that can be done. And if a top feeding is required, then what is to be given, how many hours to be given, whether demand feeding, what is to be done, and the baby's expected growth development. So in our scheme of immunization cards, the growth parameter chart is given and they can chart in that, or they can be given special charts, WHO charts, for assessment of growth and development in the first year. Again, rooming in is required. Ask the mother and the father to stop cessation or smoking cessation. If the mother is smoking a bidi or a cigarette, many of the women, the tribal or the women in the villages, they do smoke. If they decrease this, the cessation decreases the risk of FGR in future pregnancies. Now, post-discharge, they are followed up by the primary clinician or the specialists in a neonatal follow-up clinic and monitored. And appropriate referrals, timely interventions, like 4 weeks, you get the eye specialist propin and get the hearing test done. At birth or before discharge, you get a hearing test done. All these timely interventions are explained to the parents in a manner that is understandable to both of them. And many a time, a lactation consultant helps along with this. So never ever should we forget that immunization is very, very important. Explanation regarding BCG, oral polio, and hepatitis vaccine should always be given to the mother. Thank you so much for patient hearing. I will rest here. And if there are any questions, I would be happy to answer.
Thank you, ma'am, for the beautiful talk. We have no questions for the sessions.
Dr. Ishita is there?
Dr. Ishita is not here. She could.
Dr. Ritu, you conclude.
Thank you, Dr. Pyali ma'am, for such a comprehensive talk. We have learned so much today, and hopefully we would use it in our day-to-day practice. Especially music in the NICU was such a beautiful thing. And since we have no questions, I would like to end our pediatric topic over here. Thank you so much to everybody.
Thank you, ma'am, for such a beautiful talk. Our request to each and every participants and delegates that we are having a National FOGSI conference on 6th and 7th of August on the very pertinent topic, that is obstetric dilemma. We have arranged a very good faculty. My earnest request to each and everyone to please join for this conference. And नीचे इसके नीचे आपको शायद नहीं दिख रहा है, but that is www.AOGSOBDIL2022prayagraj.com. This is our और उसके अलावा आप you can contact me or Dr. Ranjana or Dr. Lalita Shukla and Dr. Chitra Pandey. Anybody in Allahabad Obstetrics and Gynecological Society, you can contact, and please do come. So before vote of thanks, Deepika, if you wanted to say something.
Thank you all for joining in today, and special thanks to all the esteemed faculty and the esteemed attendees also. We look forward to support for DIVATRONE, our micronized dydrogesterone tablets. Maintained injection is hydroxyprogesterone caproate, 250 and 500 mg. And we also have Lycored Preg sachet of L-arginine lycopene 4 mg and DHA for high-risk pregnancy cases. Thank you for your presence, and we hope to see you again.
So the time has come after this enriching scientific webinar to say formal vote of thanks. My gratitude and thanks to our our chief guest, Dr. Rishma Pai, past President FOGSI, for her support and blessings. My gratitude and heartfelt thanks to today's speaker, Dr. Khanna ma'am, Dr. Pragya Mishra Chaudhary ma'am, and Dr. Pyali ma'am. You all have made this evening a satisfying experience, and we are going back richer in knowledge. My gratitude to our chairpersons, Dr. Surjeet, Dr. Vaneet, Dr. Madhi Mittal ma'am, Dr. Gitanjali, Dr. Ritu, and Dr. Ishita. Dr. Ishita was not there, for the valuable inputs and supports. And my thanks to our co-partners, Dr. Ginny and Dr. Parul, for the smooth coordination of the webinar. Many thanks to ICOG office for granting us always some ICOG points. This time we got 2 ICOG points. And thank you. At the last, I want to thank Ludhiana and Jalandhar Society for holding our hands. And thank you, Jagsonpal, especially Dr. Deepika, for always supporting us. And in all our, I can say, अभी हम हमेशा ही हम कुछ आगे सोचते नहीं और डॉक्टर दीपिका और जैक्सनपाल को बोल देते हैं कि आप हमारा वेबिनार कराना है, and all the things go on so smoothly. Thank you so much. And again, request to come for our conference in August. Thank you so much. Thank you, Pyali ma'am. Pragya ma'am, aap bhi hai idhar, so thank you. Thank you, everyone. Thank you from the bottom of my heart.